Well, then I guess we will get our second episode started, and I will do the introductions. And the first, of course, we will introduce Anand Chokchi, who is the absolute scholar of anything physical therapy in the US PT market, who has most encyclopedic knowledge of the physical therapy world, but also has been through so many different iterations of this domain and this discipline, so that he's seen the world change time and time again. So to have you as part of this episode is an absolute honor. And Dr. Patel is a incredibly experienced physical therapist who has also been a part of the digital and hybrid systems for a long time. So who has seen the world change and who has experienced it herself and who's been an agent of this change for the last decade. So it's going to be great to discuss the 3 points that we outlined. And so without any further ado, I'll open the floor to you guys to do your own intros.
You first, Anand. Oh, thank you. Thanks, Alex. I really appreciate the introduction. If you could tell, if you can see me blushing with my skin color, you actually be seeing me blush with every time you make that intro. So I really appreciate that. Again, my name is Anand Chokchi. I'm a physical therapist. Been a physical therapist for a long time, and have been fortunate enough to have met Alex and Meenal both previously. And I've been in the digital health tech world since 2012 when I left traditional practice to start a help create a startup called Reflection Health, using sensor technology to help track patients doing their activity at home. Got out of that world, kind of always felt like, hey, how can we improve access to care and, help patients beyond the 4 walls of the clinic? All very, cliche sounding things now in a sense, and it's been there for a while, but that was really it. Every patient had my phone number, so we were able to call me so I could help them when they're, had questions when they weren't at home or weren't in the clinic with me. And, at that time, a technology called the Microsoft Kinect camera came out. So kind of looked at it and said, how can we use that to understand what patients are doing outside of the clinic? Took that company, created a lot of clinical evidence and did it systematically to then help to, with other organizations, help to write and propose the RTM codes back in 2019, 2020. And kind of been in this space ever since. Also worked with a great company called Include Health, and then did some consulting. And now I work for another AI health tech company, which is a little bit different. I try to create models of bringing new codes to fruition to help increase revenue. And now I kind of work on the other side of, helping clinicians kind of get the money that they deserve. I have earned already through technology, rather than kind of helping them with new codes. So now helping them with the revenue cycle using AI and other aspects with AI technology now.
Nice. You both have quite a bit of experience. The mere physical therapist who has been practicing for 15, 16 years, traditional outpatient orthopedic setting for the most part. I did delve into, of course, the virtual world, telehealth medicine for a little while, as that became a big ask during the COVID years that we had. And then in 2023, I left the clinical world, and just on a personal level, decided, hey, I needed a break and needed to do something different, and moved overseas, and have then since been involved on the digital side of the rehab world, on more technology that is being utilized within clinics, right? So I know one of the discussion points we have upcoming is, how are actual providers and clinicians feeling in the workspace with the technology that they're using? And I am a very, very good example of what it felt like while I was, in person, and what I can now see is the future of that. And so, and it's an exciting space to be in, and with, people like you that have, both you and Alex have experience in so many vast different areas that at this point now, are being utilized in clinics, in real life, in so many spaces. And it's just exciting to see that actually coming to fruition.
So yeah, it's terrific, and as a little caveat of scholarship on this podcast episode, reading a absolutely brilliant article and then being so excited to share it with Anang. And he's like, yeah, I wrote this article. It really is, I think, between the two of you guys, that there's just a world of experience and expertise that we can hopefully spend an hour discussing, and then this information will be translated into whoever the audience is into something that's actionable to help people move a couple of inches in the right direction. So the first question, which really should tackle, is ever mentioned staffing crisis in the MSK world in the United States. And it's been already well publicized by both APTA and other medium that we're losing anywhere between 10 to 17% of the workforce to either non-clinical jobs, or people are just leaving healthcare altogether. And I think, at least to me, that is a catastrophic way of losing 7 years of investment. I think that the average program takes 4 years of undergraduate degree and then 3 years of graduate degree. So that's 7 years of personal and societal investment that goes into ether when somebody just chooses to leave. And having said that, I also understand a little bit of hypocrisy because the three of us have predominantly non-clinical jobs. So here we are. But what is a way, I think, just how do we create an environment where clinicians are actually happy to provide clinical care instead of just looking for other opportunities? So what do you guys think?
Yeah, for me, it's like, when you think about the clinical care and just the people leaving, it's trying to understand why, right? I think, big question always becomes is the salary debt ratio of physical therapy sometimes, right? And I think, unfortunately, the pandemic kind of opened the eyes to a lot of people of work-life balance as well, a little bit. We saw as clinicians, we saw the ability to work at home. Also seeing our colleagues and friends who are not in the healthcare world having a different type of lifestyle with potentially sometimes even a greater salary and have that flexibility of working from home. And that kind of, I think, intrigued a lot of people and made them think outside the box a little bit, right? And so now when it comes to technology, how can we, because again, clinicians, as we all know, I know the reasons, why Meenal and I kind of may have left, and Alex, yourself too, is like the everyday monotony of documentation and other things, right? It's always there, the administrative work. Listen, we love talking. This is why we are on a podcast, a webinar right now, because we love to talk, right? And love to and connect with people. But the complicated aspect of being added with all the administrative tasks that are part of the job, I think sometimes is frustrating. And so, now you look out there in terms of a technology that can help. And I think it's a tip of the spear. It's not the ultimate thing that's going to help, but is this all of these ambient listening solutions that are out there, right, for clinicians? I think that is a solution that I think I would encourage a lot of clinicians to kind of experiment with, play with, understand how it can impact their lives in terms of giving back some family time and taking away the documentation time, that we always tend to do in between patients, or at lunchtime, after work, before work, or even sometimes during the patient care, right? That also then affects the ability to create or strengthen that clinician-patient relationship. I'll stop there, and I'd love to hear what you're thinking too.
Yeah, no, I think you hit the nail on the head, especially when you say, how I believe it started, even for a person like me, was to be able to see items out of the box, right? I knew what outpatient orthopedic PT, work was going to be like, but COVID came, pandemic came, and all of a sudden it was flipped upside down. The expectations were, sometimes unattainable for both the clinicians as well as the owners, and there needed to be more ideas and more, sort of inclusive ways for us to get creative on how we're going to get XYZ done, right? And unfortunately, we looked outside and all of a sudden there weren't opportunities, or there weren't places where it was going to be easy for me to see my patient necessarily outside of the clinic, and still get paid, in a very appropriate way. And so starting to think outside of the box, I think, was the biggest reason why so many people have transitioned out of in the clinic. Of course, all these other items, the administrative burden, the expectations that kept getting added on. I mean, when I started practicing, I was practicing with writing on paper, and there was no way, 5-10 years down the line, with all the expectations from insurances on MIPS and modifiers and all of these things that kept getting added on, that we were going to be able to do this on paper. And so, of course, moved to electronic systems. Now, electronic systems were they prepared and ready for outpatient physical therapy specific? No. We were using systems that were not made for us as providers and clinicians, and therefore adding more workarounds, more, hey, in order to get this physician to sign off on this, you're going to have to do 10 steps instead of just sending it to them via fax, right? So I think it's a combination of the overall healthcare system not being prepared for our particular needs, and clinicians then becoming just frustrated and overwhelmed by that, and deciding that they didn't want to have to put up with that when they could go to a work from home job that either demanded less, or also even paid more, right? And so I think overall, I do see now the trend, I think, still going towards people exploring other opportunities, but still exploring them within the physical therapy space, which is huge, because that means that innovation, that means, different ideas, as you mentioned, out of the box, and ways to get us on those of us that are on the ground, in a place where we feel happy doing what we're doing. Because, I mean, all three of us, I can vouch for the two of you, I'm sure, we love what we did. We love seeing patients. We actually still probably enjoy seeing patients. It's all the other pieces that sort of, affected our decisions.
Yeah, I love what you're saying, and I think I don't want to make it sound doom and gloom as well, right? And I think what we're seeing here in the last number of years, if we just think of the lifespan, if I think of the lifespan of my parents, my grandparents, and see how technology's evolved over time, even in the last 10 years of, for my kids using technology to me, like, I don't know half the stuff that they're using anymore, right? And how they do stuff. And the evolution of technology in the last number of years has been so exponential that I think, I don't want to make this sound doom and gloom. I think there's an incredible opportunity now to use technology as part of your practice to help you get back to what you're doing and simplify your life a little more as a clinician, and let you focus on what you want to focus on, which is patient care, right? And bringing that back in. And again, we talk about, I mentioned kind of the ambient listening solution. I think that's part of it, right? That's only tip of the spear. I think it comes down to all these administrative tasks, right? Where now you can imagine, because of things like ChatGPT and OpenAI and having these large language models out there, there's greater possibilities now of helping you not only with documentation, but you can imagine with patient intake, communication. There's so many now these, you see out there with many solutions, these AI agents that are out there having conversations, can help you with scheduling, can help you with prior authorization, with explaining things to patients, right? There's so many now, parts of the job which is frustrating, right? The prior authorization process. Mm-hmm. I think there's ways to look at how can technologies help both on the payer side to streamline this, and on the clinician side, right? Where now, rather than human time having to be spent having a very, I would say, for the easier conversations, why do we have to kind of waste human time to do that? And why not make the human more effective and more efficient for the more complicated questions and discussion that has to happen? And maybe 80% of that, that whole Pareto principle, maybe 80% of these prior auths and things can be figured out through technology, right? And sharing and grabbing and attaining the right information to get the right number, to get the right authorization there. Because again, we talk about insurance. We all know insurance, unfortunately, is going one direction. And now to even do these reauthorizations with some of these TPAs that are managing some of the visits, it's complicated, right? It's more paperwork. So how can we, but when there's repetitive stuff, how can we use technology to help us with repetitive actions? And I think there's a lot of great organizations out there that are looking at this and are doing this in a very innovative and effective way. Right?
Yeah. I think there's what you're saying is spot on, and that like there's that contextual factor even into that just experience of receiving care, or the context of erecting a wall between you and a patient when you have a laptop open and you are just clicking away, trying to capture this visit. You lose the attention and you lose the focus, and that qualitative experience of receiving care is gone because you're now no longer a patient. You are just an object that needs to be recorded and documented. And so some of these ambient technologies and some of the tech that's available really takes that away and gives you the liberty of actually focusing on the individual, and then it becomes much more natural exchange of information between I, the consumer, and you, the provider, right? So that is an absolute necessity, I think, to create this much more natural exchange of clinical care. The other part, I think, to really focus on is that with a lot of the clinicians early in their career, they have this dichotomy of job satisfaction, which they don't appreciate, which is you can be happy in your job or you can be happy with your job. And a lot of clinicians are not happy in their job because of the situational barriers, the economic barriers. But it doesn't mean that they're not happy with their job. There's something that pulled them into this career choice. And so that poor understanding of that really duality of like, I'm just frustrated because I don't have time, my quality of life is suffering. It's not because your career was wrong, it's because the environment that you're in right now is not supportive of your professional ascension, which can be helped by some of these smart solutions. Now, and this can go into a third question that I'll raise to you guys, where when somebody is making a decision to invest into a technology, to bring technology into their clinic, there's almost always a pushback, which is equivalent to the price, where people look for the cheapest option, which, right, like the payers versus users, or the people who pay don't understand how the use works, and the users can't afford to pay for it. And so when you're picking the cheapest option, doesn't always mean the best option, because these options are cheap for a reason, that they may not have the portfolio of products you're looking for, or they just may not be very functional, operational. So what would you say is the best, like maybe 3 things to look for when somebody's looking for this technology that can really efficiently support the clinical workflow?
I think.
You go ahead.
Go ahead, Anna.
Yeah.
No, I was just gonna say, to speak on the clinical workflows, is that when you look at your organization, for example, there's going to be certain stakeholders. There's going to be the clinicians, there's going to be the front office staff, there's going to be maybe the back end billing staff, and others, part of that organization. I think it's first and foremost important for whoever's making these technology decisions for the organization to really take a deep dive into where are their deficiencies, where are the largest, percentage-wise or number-wise, whatever it is, where are they experiencing backlogs and stopgaps and places that are really, affecting their overall business aspirations or goals, right? And I think most people, when they look at that, they're going to see that across their functions, front office, back end, clinical, there's going to be places where they can improve their efficiencies. For some people, it might be a larger on the clinical side, it might be smaller on the front office side, or vice versa. But when they look for solutions for this, I believe what usually happens is we try to go for the quickest fix, right? We try to go for, hey, let's fix that. The clinicians are super unhappy with documentation. Let's go for a system that's going to help them with documentation. Not necessarily then looking at the overall product, if it's also going to help with their front office staff or their back end billing, or vice versa. Hey, billing is a really, really big problem for us. Let's go ahead and get something for billing, but then what are we now going to do for the clinicians? And as Anang mentioned earlier, there has been so much rapid growth in technology over the past 5-10 years in the physical therapy rehab space, that it no longer should suffice a organization to only look for a solution for one particular thing and then to have add-ons for everything else, down the line and fix it, fix this kind of snowball that kind of keeps building over and over with just, a little bit of a stop here and there. I think it for small organizations, one therapist, mobile practice, to large organizations, it no longer serves them that purpose to just kind of think tunnel vision with those kinds of things. And so, when you're looking to find a technology that is going to help with X, Y, and Z, at the end of the day, the onus comes on you, the decision maker, to look at where and how much and what depths need to be addressed for efficiencies, and include your staff, right? There's no other way to increase and improve adoption of a decision you're making than to include them. And yeah, maybe you don't want to hear what they all have to say, in real and in truth, but it is probably very important, because at the end of the day, they are the users, as Alex has mentioned, right? They are the people who are going to be clicking the buttons and making sure that the patient gets in, but then what, right? So that's just kind of how I think on a larger kind of overall view, how technology decisions can be made simpler, but then of course there are more steps along the way that need to be addressed as well.
I love to, can I just say ditto, right? I think it's basically, I love everything that Meenal said, right? And I actually like a couple of the last thing you said, right? I think involving the staff. I know it's always a complicated thing to do, but I think, it's very important, especially in the outpatient physical therapy space. Understand in hospitals where you have larger staff, it's hard. But I think we'll be talking about data and data transparency. I think it's being transparent about this as well, because I think we have to, gauge and understand, we are creatures of habit. And so we are used to our deficiencies or inefficiencies that we are using, and we've made them efficient, right? And we don't understand how newer technology or newer ways that are out there to potentially take away. So when you talk honestly, sometimes as I've built, we've all built some solutions, and you have conversations with people who are trying to implement digital solutions. Sometimes they want those same inefficiencies in their workflow, because guess what? They're used to doing those 4 different steps, right? But it's like, hey, if you can go from step A to step G, is that better? You don't need the A, B, C, D, all the stuff in the middle. But sometimes they're so used to doing that, they ask for all those steps, right? So when you bring them something new, which goes from A to G, they're like, whoa, they just feel like, completely lost, right? And not really aware. And then when you walk them through it, I think that's it. And I think, Meenal, what you said again too is recognizing your pain points, right? Not just the pain points, I think, for the staff, the clinical staff, but the pain points of the workflow of I would say the patient journey from the very beginning, right? And that includes, finding your office, to patient intake, to scheduling. When we talk about technology, we all work in the PT space, and I'm calling in the medical space, and I'm calling physical therapy clinics, medical clinics. You know what I really hate? I'm calling in to sell a product, okay, or talk to someone. If I'm a patient, I'm calling into these clinics, and I get these phone trees, and push 1 for this, 2 for this, 3 for this, and and then once you push it, you're 5th in line. And you'll be answered in 2 minutes, but I'm still on the phone for 8 minutes, 10 minutes. I just want to schedule, excuse my language, a damn appointment, right? I want to schedule a damn appointment. Just let me schedule an appointment. I want to come see you, but I'm waiting in this. And I get it, because why? Your front desk is so busy, right? Helping people, taking it, being the front face of your clinic, right? And guiding people, and checking people in, collecting money. So how can you streamline their workflow to potentially open up them to answer phones? And if they can't answer the phone, what are the other options that are out there to help this person who needs your help get into the clinic, right? And so when you look at technologies, what I'm thinking, I want people to think bigger, right? And so you think of your pain points, but think very large. And when you talk to organizations, understand their mission and their vision of their organization, and understand kind of what's the future of this company, right? Are they just building something right now here? And I love what you said about these add-ons, right? There's so many great companies that are out there, but sometimes when you work with some organizations that are adding other companies onto their platform, I think there could be potential for struggle down the road if technology changes or something changes on the back end where the integration is not as smooth as it should be, because there are 2, 3, 4, 5, 7, 8 different companies onto one platform, right? So I think looking at that and last thing I'll say too is sometimes as clinicians, and we're really, we just take what's given to us sometimes. And what I mean by that is, here's something we got to use because this is how you use it out of the box, right? This is what you get. Here's your widget, use the widget.
Yeah.
I'm not a big fan of that. I think you need to talk to organizations and understand what organizations have some customizability to them, who can adapt to your workflow, because it's not into your multiple clinics if you're a multiple clinic organization, because one clinic in one area doesn't operate the same as another clinic in another area. They have different cultures, different people, different patients coming in, so they have to operate differently. So having that customizability in the platform that you're adopting is really key, because again, not everything's the same, right? And I'll kind of stop there on there.
No, I think that's there's a perfect testament to human nature. I think there was an experiment that looked into the Google Maps data when there was construction in New York City. And what they found is that because of the construction, the commuters going from point A to point B had to take a reroute that actually saved them 20% of time. And the construction was going on for about 3 months. So they wanted to see what was the percentage of people that would resume their inefficient route after the construction was over, and what's the percentage of people that would stick to the new route, right, that they've discovered. And there was like 95% return to the inefficiency. It's like, right, so that like just the old and tested, and even though it takes me 20% longer to get there, I know these streets, which is, if you think about it, it's completely illogical, because that's 20% of your time you never get back. But the human nature still prevails that, I know how to do this. I know how to take that step A, B, C, D, E, F, G. And if you tell me a shortcut between A and G and that I feel something is missing, when you're like, no, that's 10 minutes of your time. You're welcome, sir. Right? Yeah. I think Richard Taylor has in choice in behavioral economics. There are 2 concepts that are brilliant. One is nudge, right? Nudging people into good behavior, and the other concept is called sludge, which is the opposite. It's the antithesis of nudge. Like companies creating these sludge points, these friction points. So when you're calling your insurance company and you're on hold for 45 minutes, that hold is there for a reason. They want you to hang up and not call. So there's a lot of these. I think that the base foundation, I think that buyers can make a conscious effort to create these nudge choice architecture for clinicians to actually feel happy, and then break them away from their even maybe like maladaptive behavior that I know how to do this and I've done this before, and I'm just going to take this longer route because it is what it is. So let's move to the next question, guys. The next question is about the cost barriers, and I think that how, based on the current environment, right, the cost structure, the fee-for-service model in the United States is consistently being cut, and so now, like year after year, clinicians and business owners have to do more with less. And there's 2 ways of dealing with this and adjusting your business model when you're doing more with less. One is just get more of more so that you can work with less, so then you just increase volume at the cost of quality and efficiency and value. And the second point is to actually look into that cost efficiency, that paradox where like the happiest person in the world is the one that needs 99 cents to survive and he has $1, and the saddest person in the world is the one that needs 99 cents to survive and he has 98 cents, right? It's a small adjustments to business cycle that can actually help you become much more operationally sound without getting more income into it. So I'll open the floor for you guys to reflect.
When I think of that, obviously, when it comes to fee-for-service, it's still the dominating force in our clinical world, right? And so, and as we all know, insurance companies are not increasing the reimbursement value that's coming back to us, even though we are fighting and showing the value of physical therapy and how we can be not seen as cost, but more than cost savers, more than just pure cost, right? Obviously, there's that study from the APTA for those different diagnoses out there, right? I can't remember. It's like epicondylitis, I think it was fall prevention,
osteoarthritis.
Right. There was a few of them, right? And showing how we can be downstream savers. Unfortunately, right, we are a little bit downstream, right? But at the same time, I think, showing our value more, I think it will help us, right? And so that can be done a little bit of, I know this word's been around for years and years and years, and there's parts of it, but it's this value-based care, right? It's looking at that value-based care. Or sometimes, when it comes to this, I'm seeing, and you guys are probably hearing this too, more and more clinics are going out of network, right? And going out of network with insurances to prove their value, to show the value, right? Because they have more value than what they're getting from these insurance companies. So exploring those options, taking the insurance company out of the middle of this conversation between the consumer and us, and maybe going directly to things like these large-based employers as well. So working directly with employers. Getting those type of contracts, right? Again, easy to talk about, not necessarily easy to do, right? I know there's a lot of great courses. There's some great organizations out there that help you and guide you with this, or have built platforms to support you on this type of initiative. But thinking of alternative ways of helping patients, right? Beyond just the fee-for-service world. Maybe it's cash-based programs, post-discharge. But when it comes down to as well is collecting the right data so that you can have these educated conversations with payers, with employers, to show your true value, right? And that comes from outcome data, and potentially showing how you can save downstream costs from surgical intervention. Right? Listen. In the PT world, there's a couple of companies, digital healthcare companies out there that everyone fears, right? And I don't know, are we allowed to say those names or not, Alex?
Yeah. I think, why not, right? Let's go crazy.
Why not? Yeah. We fear with the type of care that's sometimes delivered by the swords of the worlds and the hinges of the worlds, right? Because they're delivering employer-based type of care. And I'm a big believer, and I think the three of us are big believers in hybrid model care. Every patient's a hybrid patient. There's a dial to that patient, and that dial can be all virtual, all in person, and whatever that percentage is, right? And I think being able to come with a hybrid type of platform or service is going to make us more, I think, attractable in the future to this, because I think this all virtual care is great for some people, the motivated person, but if some people really need that hands-on care, you need to get them into the clinic today, not tomorrow, not next week, not 2 weeks from now. So I think finding that little strategies there as well.
Yeah, those are great points, Anang. I think there's no other option for many organizations these days but to diversify on what they're going to be offering for their patients, right? Years ago, the purely insurance-based model worked, and they paid great, and they reimbursed what was out there, and that's how it went. And of course, that has changed drastically over time. And I think the unfortunate situation physical therapy or rehab has been in, especially in the outpatient world, is that we've not sort of kept up with those rapid changes on the provider and the insurance side of things, with either our models in the clinic or our technology, which would have allowed us to maybe stay on par with what's happening in that reimbursement world. And so of course that has all kind of come out to the point of maybe needing to diversify cash-based services, package services, out of network, different virtual versus in-person visits. And so I think at the end of the day, if I spoke on a clinician lens purely, what I provided to my patients when I was in person treating them was always value-based care, right? It was always, I was going to treat them to make sure that every session that I saw them for was going to have an outcome that was beneficial and past that threshold the next time around, and the next time around, the next time around. The struggle came in where either the technology I was using at the time, which is very true, that it didn't exist enough for me to even collate that data, right? To have outcome measures I was providing them at initial eval, at progress, at discharge. It was all there. It was all on paper. It was all somewhere, but there was no place where, me as a physical therapist, I could collate all that data and say, hey, look, this is what I've been doing for my patients all along. And of course, now we're seeing that that's non-negotiable. We need to have that data. We need to have that information. We need to have that at our fingertips to be able to discuss with our providers when we're, renegotiating rates for our CPT codes and all that, or even just, again, showing our patients, hey, look, this is where you've gone. You've gone from this to this, and if you've been happy with the care, it looks like you're probably going to refer somebody else to me, right? So we don't have to work in that volume-based environment if we're providing the care that we should be providing, if we had the time to provide the care we should be providing, right? It's such a circle that if on the basic level as a clinician, I had the time to do what I needed to do, a lot of these conversations wouldn't necessarily even be part of the situation, right? I would be providing great care to my patients because I had the time to do it. They would refer. I would then see another patient because they referred. All of a sudden, I don't have enough space on my schedule. I'd hire another therapist, and so on and so forth, right? It's a very simplistic way of looking at it, for sure. I understand that, but at the same time, if we were just peel off all the layers, I think there are things that can be done, even if you are in a fee-for-service, situation, that can help you with technology, with processes, with efficiencies you create in your clinic, to not have to be burdened to that, or to not have to be, bound to that for the rest of your business life, right?
Yeah.
I think. Oh, go ahead, Alex. Go ahead.
No, go ahead.
I was just going to say, when it comes, we're talking about creating new models of care, right? And new opportunities out there. And I think that's part of it. But at the same time, I also think, and I think we all touched on this a little bit earlier too, is like fighting for the money you've already earned, right? And getting the money that you've already earned and deserved, right? From insurance companies. There are articles out there that are talking about technology and technology being used by payers to deny 20% of their claims in 1.6 seconds, right? And just, again, a human's not reviewing it, just denying it because they're throwing technology at it. But why are we fighting that sometimes with, we're going to a gunfight with a knife or a slingshot, right? I think as organizations, medical organizations, this is not just PT, medical organizations as a whole, we need to be armed with the same type of gun and fight them with that same sort of power, right? And come back and say, make it a fair fight. And say we have similar technology to make sure we understand, using these large language models that are out there to understand what are these payer policies. Are we getting paid what our payer contract says, right? Are we getting paid, or are we getting dollars less based on our Noridian contract for Medicare? How do we know that when we're so busy as clinicians, or not even as clinic owners and that, and we're so focused on keeping our staff happy, keeping our staff happy, keeping our patients happy, keeping the clinic flowing. Sometimes we don't even have time to understand the business side of the business and making sure the business is running smoothly until we take a step back and take away time from family, which is hard when you're already working all day. So having those types of technologies in place, right, to understand that and making sure that we're getting paid where we are is really important as well.
I think it would be a very interesting thought experiment. What do you think is a percentage of all of individuals holding contracts with these payers who have looked into these contracts in the last 12 months? So like what's a percentage of business owners that actually look into these contracts year after year and saying that I need to negotiate this contract? Now, is there a complacency that I've signed this contract in 2017 and now 2025, I'm still continuing to operate under the same pretense, right? Where else in our life do we continue to follow a resolution that we signed a decade ago? But I think here you have just poor awareness, and that poor awareness breeds contempt, because then you're operating and you're operating on less. And you're absolutely right, Anand, that you have someone who's not even willing to arm themselves with advanced technology, because what they're doing is they feel like they're following their mission. But if you look into that, the foundation of value that you were mentioning, value is cost over outcome, right? It's a simple equation. It's what is the cost of operating and what is the outcome I'm producing. And so that cost over outcome, that cost climbs, the outcome may be stagnant. Like, how do you manipulate that formula, right? So it's really good. But just to use both of your guys' reference point and knowledge and awareness, describe or at least elaborate what is automation and how does automation work in this specific domain.
With respect to reimbursement,
Uh-huh.
you right?
Yeah,
So I think I'm gonna jump ahead, not jump ahead, but kind of our last question we have is data, right? Data is gold, and really turning that insights into action. And when you talk about all this stuff that we're talking about now in reimbursement, the problem is we don't have transparency into our data. So it's hard for us to draw insights into and trends of what's going on day to day to translate that and make business decisions sometimes, right? Because it's not really easily presented to us. It may be presented to us at the end of the month report, not day to day. So I think when you think of this, is like, look, there are ways now, again, of writing rules, right? Writing rules for scrubbing claims, to making sure claims are going in cleaner, because the cleaner the claims go in, we work in a small margin industry, unfortunately, right? Mm-hmm. And so the cleaner that we get paid, the cleaner the claims go in, the faster we get paid, the better the margin. Every time a human has to touch that claim, the margins go down, right? And again, when the margins go down, when claims have to be resubmitted and all that, and sometimes really skilled billers are out there who are doing and managing it. But again, I think there's a stat out there where if a new denial comes through, a skilled biller will still take 20 minutes to solve that new claim, because you have to go and understand what the problem is, what the resolution is, and then resubmit that. When it comes to technology can do that much quicker, and not a single item one by one. They can do that in bulk. They can categorize all these denials into buckets and then solve these buckets, right, with the same, because they have the same solution, by then throwing technology at it without having the human having to interact. So what you do get then is, what we have sometimes in patient or in reimbursement is timely filing. Right. So when we're not filing claims at the right time. And to me, it's really making data more transparent. So where's the claims, where's the status of the claims, what are you charging? Again, you can't submit a claim until a note has been closed. So how many encounters have you had? How many notes have been closed? Where are those encounters, closed encounters, in terms of the process of claim submission, reimbursement, reconciliation, knowing your numbers so you can make active decisions right away. Because if hey, I'm getting, Aetna or United Healthcare is making me fight for my money 40% of the time, you can make the business decision. Do I want to take that insurance as often, right? Understanding that, how much you have to fight for those numbers, and then making sure, you're not getting those $0 encounters, which ends up being free visits given away because you're not filing in the right way, or you're not filing in a timely way, et cetera, et cetera. So I think data is the key, right, for all of this.
Yeah, I think. Go ahead, Alex.
I was just gonna add that I don't know a single restaurant that would survive when 30% of their meals go unpaid for, right? Yes. And that's clinics operate on that routinely, that 30% of claims go unpaid, but restaurants, right, you pay at the time of your service. So go ahead.
That's right.
Yeah, no, it's exactly, as Anand was speaking, it's exactly the analogy in my head. There's not many other industries out there that are okay with payment after the fact, if maybe we'll see, kind of a thing, right? And so for businesses practices, and let's face it, right? I mean, we're not just talking about big, large organizations. Larger organizations have maybe more bandwidth to have more eyes on these kinds of things and to have, checks and balances and things like that. We're talking about even smaller organizations that operate, see many patients and should be quite, profitable and should have happy staff and all of that, struggling with these things because, as Anang mentioned, it still takes a human to then process whatever has happened. And that time will then amount to cost, right? So whether that's time for that person's role or time for other things that they could have done, for patient care or contacting patients, whatever it is, there's so many other opportunities that can be utilized with that time. But to speak specifically about reimbursements as well, I think a bigger aspect is a lot of these organizations being aware of, as you mentioned, data-wise, what should I be collecting from my patient from the start, right? It's one thing to for you to have your negotiated rates with your payers. It's also another thing for the patient to have a rate with their benefits with their insurance provider, that all three have to kind of meet in the middle to understand exactly what's going to happen at the end of the day for seeing this patient. And so if organizations can get that view prior to even seeing the patient, prior to the patient coming in, understand what the benefits are, how much is the patient going to owe out of pocket, co-pays, deductibles, co-insurances, whatever it may be. And now what are we doing? Are we waiting till after the claim has been processed and it's gone through its whole cycle for them to collect those items that should have been are items they would have owed even prior to the claim being submitted? And in that case, as Anang mentioned, a small profit margin, it's going to be very, very important to collect those items ahead of time, because then you're not going to chase those patient responsibilities after the fact. So insurance paying one thing, likely for many situations, they're not going to pay the full thing. And now what is the patient's balance now that we need to collect on? And so to leave that for after the fact is also hurting many organizations, because they, let's face it, they have a relationship with their patients that they don't want to always ask for this payment. And the write-off, as you mentioned, Alex, what is the percentage of clients or organizations looking at their contracts? I would also say, what is the percentage of organizations writing off amounts at the end of the day for services that they have provided? It's not anything that they should write off, or it's services they have provided and now they're writing off because they don't have this workflow of being able to appropriately collect and process all this prior to even seeing the patient. So I think on both ends, we can do better on the front end, and we can certainly do better on the back end after a therapist has seen their patient.
If you want a first-person perspective, sorry, it's just a more recent experience. I don't know if you guys have ever had your wisdom teeth removed, right? But having a kid getting the wisdom teeth removed, there's a local anesthetic that's being used, and like that. So you have an anesthesiologist that moonlights to these dental offices, and when the procedure takes 5 minutes longer than what he's been reimbursed for, this anesthesiologist comes back into the waiting room with his Apple Pay kiosk, saying, this took 5 minutes longer, so it'll be another $278, please. Would you like to pay with a credit card, or do you want a Zelle? It's completely transactional economics. There's no stigma against anesthesiologists asking for a pretty viable amount of money because his procedure took longer, and so he has to compensate himself for that time. We as professionals have this weird stigma of feeling guilty about being asked to get paid for what we do, which is, I don't know where it came from, whether it's indoctrinated into us or it's just something that's that needs to change. We need to be very comfortable being asked to be paid fairly for the services we provide when we know we provide services that are of value. Certainly, if you don't feel like you're doing anything of value, you shouldn't be practicing. But if you are practicing and you are providing care, there is no latency. There's no reason for latency. You get paid for what you do, and with it, I think comes that what I think Anang and Mil were mentioning, that transparency of data, and we need to get out of our silos of not knowing or not wanting to talk about it. But we need to be able to comfortably discuss, and we need to be able to comfortably ask for fair reimbursement from consumers because they've consumed our care, they've consumed our service. So, sorry.
No, I love that example because I was going to kind of hit on something very similar because I think when it comes to to all of this payment, it goes back to what we all said. Like Mila said, because we don't collect payment responsibility sometimes upfront, or not transparent with that upfront, or we don't know the data enough of it upfront, we feel guilty 6 months, 3 months down the road when the insurance company says we're not paying for this, to go back to the patient, because you don't want to ruin that relationship, because you want them to come back and refer more people, and then it can affect the relationship. And so I think I remember back when I was managing a clinic, we would get our VOBs, right, the verification of benefits, at the beginning of an episode of care, right, from our biller. And so we would then charge that patient the same thing throughout the visit. But now there's technology out there that can log in to all the clearinghouses, all the payer portals before every visit, and get the most updated patient responsibility prior to the visit. So what I mean by that is sometimes the patient will say, oh well, yes, I have a deductible, but I had a surgery last week, so my deductible hasn't been paid yet. So can I just pay the copay? You're negotiating all this stuff, right? So I think what becomes really important is, again, do you spend time with people having to be on the phone to check in with eligibility every time, every visit? Of course we don't do that, right? We do it at the beginning of the episode and then we're done. But then, do we collect too much money or collect incorrect amounts based on the information we had at the beginning episode, which things translate and change over that episode of care, because we are treating patients for anywhere from 4 to 6 to 8 to 10 to 12 weeks, right? So that number changes. So how can we get the most up-to-date number so we are balancing our books better, so we don't owe patients money back, or they have a credit with us because we over-collected or under-collected, right? And going back to what you said, Alex, of the doctor coming out with the pay system, I go, today, for anything in life, right, we are paying things in advance by text message and all this other stuff. Again, these are type of technologies that we need to incorporate into our practices to collect the money that are owed to us, right? Because again, the person at the front sometimes will say, oh, I'll pay later. There's a higher percentage of people who are paying online through a text link or an email, putting in their credit card information. So those are things we need to take advantage of as a practice, as a medical organization, to collect the monies that we are owed in a more effective and efficient manner, more than just always relying on paper statements. Like, honestly, you get a paper bill, who the heck's going to mail a check? Who has checks, right? Account, right? I had my kid write a check the other day, and she had no idea how to write a check, right? And everything like that. So that's the way, right? To kind of think about it, right? How do we modernize the way we collect what we're owed?
So I think this is a perfect segue into the last point before we complete this episode, which is, again, to speak about data. The data needs a very well-aligned framework, and data needs an anchor. And so when benchmarking performance based on both clinical data as well as operational data, there is very little in terms of individual understanding or awareness of what the benchmarks look like, both industry-wide, but then also local benchmarks and performance benchmarks for each individual clinic. This, I guess, the global term of business intelligence is really not intelligent. Because we have a non-intelligent business intelligence unit that are operating based on these wild heuristics of no specific objectivity. So how do we go about this as an industry to create a great, more transparent, more visible, more available benchmark data, and then a framework of operational data that serves as a point of reference, so that we know more or less if we are within a normal frame, or if we're underperforming or performing better than average, right? So,
I'll talk about it in two ways, right? I know you're talking about more operational, fiscal, of an organization, but I'll even talk about the clinical part of it, right? just because of the background where I've come, where I've been in, where you're collecting data on patients' activities outside of the clinic and trying to present that back to the clinician in an effective way in order for them to help them make the right clinical decisions for that patient and manage that patient more effectively, right? And make the right clinical decisions. And so, I think we all think data is king, right? And data is value, and we all know that. But I think at times, we think as a profession sometimes that we use data, right? But I think we use very simplistic data sometimes, and we don't take in other types of data that could be out there. When it comes to the adoption of digital technologies, right? You have more or different type of data now coming in. But how does that data come in, and how does that affect the way you treat, right? So obviously with this remote monitoring codes and other care management codes out there, if you get information coming in on patients' compliance or adherence, okay, great. How does that really affect the way you change the way you manage or care of the patient? What does that mean, right? If you get back and say someone is, 75% compliant, Alex is 75% compliant with his home program, and Meenal is 64% compliant with the home program. Okay, what does that mean? Clinically, what does that mean to me? I don't know what the heck that means. Does that mean Alex is better than Meenal, or Meenal is doing better than Alex? I don't know, right? Because I have no standardized KPIs to measure that against, right? And so, but now you have to take the data, I think, for clinicians and make it into a story, right? The data, it can't be just data presented. Here's the data. Now you go interpret it. The data has to be actionable, and data has to have some insights and action associated with it. So now if I kind of change it and say, hey, you know what? Meenal's logged in 5.6 days of the week and done her exercises, and Alex is only logged in 3.4 days a week. All right, as a clinician, that makes more clinical relevance to me, and I can understand the value of that more than this percentage number that doesn't really correlate to how I practice. And I think that comes with relation to both clinical work and clinical technologies that are being adopted in practice. You can't just tell someone, accuracy of velocity of movement for an activity when they're not used to seeing that data, because they don't know how to use that data as part of clinical care. Again, the same thing comes with the financial aspects. If you're presenting financial data to them, which they've never been privy to or understand, then it's hard for them to understand how to use that data most effectively. And then, even though you're delivering incredible value, the value is not perceived because they don't see the value in the data, because it just seems like it's more work, right? And so I think when it comes to turning these insights into actions, as you talk about, Alex, it's really making sure the data is telling a good story in order to help the business owner make the right decision, helping the clinician make the right decision for the patient, in order for it to have an effect on their day-to-day activity.
Yeah, I think the only thing I would add to that, and you'd hit everything again, hit every point. The story is the most important thing. The data will be present and available. I mean, again, the technology out there is doing that for us, but it's the story we tell the users about that data that's going to make the ultimate difference. And I think, again, exciting to be in this physical therapy rehab space, because there are more organizations that are collecting data that are making it very specific to our world nowadays. And so it's going to relate to us more, and we can make better decisions because of that now.
And one thing I'll add too, and this is where going back to what you said earlier about add-ons, right? Mm-hmm. The problem when it comes with add-ons, right, is that with add-ons, everything has valuable data, but the data is siloed into that add-on, right? And so where do clinicians live? Clinicians live in their EMR and their scheduling system. So anything that's outside of that system is valuable, but again, it's not going to be it's not going to be as easily, I would say, adopted if it were integrated into that singular platform, right? Because again, now, if I have to take the story of this digital technology data and then take the story of this financial data over here, because it's in a different system, and then take my clinical care data, outcome data, which is in one system, and then my notes is which is another system, I have to, as a clinician now, take those 4 silos, put them together into a way for me to understand how to manage or treat or take care of my patient. That's difficult. And that's time consuming, right? And I don't have time for that because I feel overburdened. I feel like I have a lot going on. There's a lot going on, and rightfully so in the clinic, right? Because other patients are coming. One patient came in early, one patient came in late, and my right patient is out here. So I'm just overburdened right now. So I can't make that story. But if we can capture that data into a place where that data is presented, and then going back to what you said, delivering that story and that data on, here's 2 to 3 things you need to do with this person today, or that can influence your care with that person today, or influence the care for that person remotely today, whatever it may be. They need to reach out. They need to improve, to update to their home program, whatever it may be. And that even goes back to customer service part, right? That in terms of this person, if you have that data to then do a kind of a reach out to that person, not for clinical basis, just a check-in basis as well as a customer service, right? Which is really important as well, which the front desk could do, all those other things as well.
Yeah, I think this actually creates a perfect closure to the last hour, which is human versus technology. Humans have this complete insensitivity to numbers. We just don't have good appreciation of numbers, and we don't process them the same way as technology does. So how do we enhance our care qualitatively through these systems, and how do these systems help us do what we do? And I think one of the most important things is that the data that's visualized is much better received. So the visual analysis of data. The other one is to a stored narrative from data is like a lot of it is sense making. So we can make sense of it when it applies to a specific story. So definitely there's a lot of how we as Homo sapiens can process and deliver care, but then technology that supports our care can be there as a rock, of the foundational rock to help us deliver care. So that has been perfect, and I thank you guys both for doing this. This has been a really insightful hour. So I will leave this be, but again, Anang and Minal, thank you for your knowledge, your understanding, and all the value you provide to our clinical community.
Thank you.
Thank
for the
you
time. Really
both.
appreciate it. Yeah,
Thank you.
likewise.
Yes.
Thank you both. Really appreciate it.
Yeah, been great. So.
Sounds good. Have a good day, everybody.
Yeah. Have a good day.
Bye now.
Okay. Cool.